to our webinar series called Managing the Massive Measures, Real People's Real Data Made Useful. This webinar series has been really delightful and engaging. We've had quite a number of individuals having vigorous conversations about the various tools and platforms that we've been able to share with you, and we're very pleased today to offer i2b2, a platform that you're going to hear about from 3 presenters. Before I introduce those presenters, I'll let you know that I'm Sharon Terry, President and CEO of Genetic Alliance. This webinar series is recorded, and so it is available to you in our archive section. All of the slides, the presentations, and all of the questions are available to you there. During the presentation, we encourage you to ask questions, and how we do that, because there's too many of you to leave off mute, is ask you to type your question in the box in the GoToWebinar control panel. You'll find that usually on the right side of your screen. It's an independent floating panel. You can put your question in there at any time, and we will tee those up for our speakers once they've finished their formal presentation, and we'll promise to get through as many of those questions as we can. And if there's any that we don't get through, we often try to get through to them after and get the answer to you. So again, this is recorded. You can ask questions throughout. Feel free to type them in the boxes. And without further ado, I'm going to introduce our 3 speakers who today will present i2b2 to you. So the first will be Paul Avillach. Hopefully I said that right, Paul. You can correct me when it's time. We'll also have Dak Kohani and Sean Murphy. And the 3 of them will share with us what is i2b2 and why should we care. Thank you.
Thank you for the opportunity to chat with you all. I'm talking about i2b2, which we speak of as if it were a software toolkit, which it is. But in fact, it originally was an acronym for a grant, Informatics for Integrating Biology and the Bedside, so 2 I's, 2 B's. And this was one of the National Centers of Biomedical Computing that, in fact, still is in existence here at Harvard and the affiliated hospitals. And it's become, as you'll discover, a fairly widely used translational toolkit. But why did we do this in the first place? We did this in the first place because we were acutely aware, this was back in 2003, 2004, that the following equation that you see at the top of the screen, which is an oversimplification of standard population genetics, told us where the problem was going to be in understanding the basis of a lot of human diseases. That is that the variance of the phenotype, BP, is equal to the variance of the genotype plus the variance of the environment plus the variance of their interactions. Now, paradoxically, in a way that none of us would have anticipated 10 years ago or maybe 15 years ago, certainly not 10 years ago, the variance of the genotype is actually the one that we have best quantified, thankfully, to the efforts of the NIH and industry in developing unbelievably cost-effective, very rapid sequencing methods. What has lagged considerably far behind is understanding the variance of the phenotype, because we don't characterize the phenotype well, and even larger black hole is the variance in the environment, and therefore it's essentially impossible to calculate in a systematic way the variations of the gene and environment. And just to give you a sense of what the landscape looks like, this is actually taken from a JAM article that we published, actually, that just appeared today in the Journal of the American Medical Association, to give you a full landscape of what are the data that pertain to human disease. And it makes very clear, as you stare at this rather complex diagram, that there are both structured data and unstructured data, and a variety of sources of it, going from the medical system, classical medical system, all the way to genomics, but the social web. And all these have different distributions, biases, and challenges in joining them. For i2b2, our first challenge was joining the genomics to the clinical data that is acquired in our already expensive healthcare system. And given the fixed costs that we've already sunk in healthcare, can we actually use that data that's acquired really to care for patients and to get reimbursed for patient care, can we use that same data and repurpose it for discovery research? One measure of our success is that our system, i2b2, has now been adopted, as shown metaphorically, or not metaphorically, literally, by this map of the globe, has been adopted by over 100 academic health centers internationally. And as I like to say, it may be free and open source, but it's free like a pony. You have to feed it, and you have to clean up after it. And what that really means is that the institutions that have picked it up, these major academic health centers, have to pay for or invest in extracting data from their electronic health records, for maintaining the database, for maintaining the applications on top of it. So it's a major investment, and yet, because it's allowed them to do a variety of important analytic tasks, including the ones around finding the genomic basis of disease, it's become fairly widespread. I'm just going to give you a screenshot of the i2b2 workbench so you have a sense of what it might look like. On the left are a variety of ontologies that allow you to look at the data, and in the middle over here are some boxes where you can combine in Boolean fashion the various attributes from the genomic to the clinical. And here in the bottom panel is a set of hash marks for each data type for a given patient, so you can see how that patient looks like, and when you click on those hash marks, you get the full textual note. Importantly, because we recognized early on in our proposal for i2b2 that although most analysis of the healthcare system has been based on claims data, those claims data are not only coarse-grained, but they're biased for maximization of reimbursement, and therefore, as poor as they may sometimes be, the clinical notes were important to be able to extract what the doctors were trying to say to one another, and we used natural language processing methods to do so very extensively. This next screen just shows you that by using a healthcare system, we're able to acquire the discarded samples that correspond to those patients very rapidly. Shown on the x-axis here are weeks in a year, on the y-axis hundreds of samples, and you see for common diseases like asthma and major depression, even in a relatively small healthcare system with only a couple million patients, you can acquire on the order of 1,000 samples per week for those common diseases, maybe 500 samples or 300 samples per week for something like rheumatoid arthritis, and for something as rare as hen's teeth like Huntington's disease, still an impressive 3 or 4 per week. And because we're using discarded samples, and because we're using phenotyping through not the use of research assistants, but through natural language processing and the codified data together, we have literally order of magnitude improvements in scale, and this causes disruption in a positive sense of the economics of large genomic studies. And you see here a few graphs from a genome research article we published back in 2009. And it shows here, for example, if you wanted to do a 20,000 patient study, it would cost you approximately $25 million. With the techniques that we developed for i2b2, probably closer to about $2 million. And for a while, the HHS was talking about doing a 1 million patient study, and they had estimated about $3 billion. We estimated even without doing anything special, it probably would not be more than $1.2 billion, but using the techniques we've described, probably more like $160 million. And to make the point about what this actually does, here's a graph that our collaborators in i2b2 rheumatoid arthritis did, and it just shows that we were able to reproduce a previous GWAS shown with the blue dots, where on the x-axis are individual SNPs, on the y-axis are the odds ratios, and you see that our study, which was done far more cheaply and far more rapidly, is for a GWAS remarkably superimposable on top of the original studies. And very important to note, once we had put in place all the infrastructure, not only were we able to reproduce that GWAS at well below 1/10 of the cost, and 1/10 of the time, but we were able to rerun the same analysis at the push of a button for African Americans and Hispanic Americans, who are traditionally underrepresented very, very underrepresented in GWAS. And this, I think, is understood by many to be a social problem. And by using the healthcare system in this fashion, I think we can begin to address it. This other slide I show just to remind other uses of i2b2, which is introspecting into the healthcare system processes itself. And this shows a couple of notable hospitals that we published about back, I think, in 2007, where there was this big increase in heart attacks that were unbeknownst to the healthcare system. And after the fact, we realized that no one had realized that we had gone through this large mountain of morbidity. And in fact, if you look closely at what happened, the beginning of that mountain was the onset of treatment of Avillach. The end of the mountain was the end of the treatment of Avillach. The peak was when the first big news reports came out about it. And had there existed the kind of infrastructure we now have, we could have perhaps detected this early on in a systematic fashion. Now, Sharon Terry would be probably the first to recognize that it's very hard to share data among healthcare systems, which often compete. And in fact, the closer they are to one another geographically, the more reluctant they are often to compete. And so therefore, we were very pleased when we were able to create a informatics infrastructure that we will talk more about in another webinar called the Shared Health Research Informatics Network, or SHRINE. And what SHRINE does, it says everybody should keep their data locally because, in fact, they are the guarantors of privacy of that data, and they are the ones who have that relationship. But we were able to create this peer-to-peer network, much like the file sharing networks for MP3s, except with the right IRB oversight and the right security architectures. We were able to create this SHRINE architecture and implement it at Harvard, and it's been adopted in several other systems, including the system, UC Rec system for the University of California. But merely at Harvard, taking 5 relatively small hospitals, we were able to aggregate 10 billion facts across 6 million patients and put in place the IRB surround such that, as shown here, completely independently of us, a group of individuals studying a very rare disease that kills women in their 3rd trimester, peripartum cardiomyopathy. These investigators had a handful of patients that they had developed, I think, some very interesting hypotheses around the mechanism for these patients. But they only had a handful of these patients. And by using SHRINE, they were able to get more like 4 handfuls of patients, so they actually could really determine much more solidly this phenomenon, and furthermore publish it in Nature. And I think this goes to show how if you create infrastructures that allow these large healthcare systems to coalesce, then regionally and probably nationally, we can now go on and have a much better ability not only to find weak effects across large populations, but also find those rare patients. I'll just end by saying that this has been the work of lots of individuals, some of which you'll hear from momentarily, and I'll be glad to take questions when we come to the question answering part of this session. Next up is Sean Murphy, who is actually the architect of i2b2 and is a neurologist by training and runs the research IT infrastructure for Partners Healthcare System.
So thanks, Zach. The next part is going to be about some of the i2b2 platform nitty-gritties and how the software is actually enabling many of those things that Zach discussed. And it really is not, and you'll see, it's not been an effort that is just our group. In fact, really, I think all we did was build a platform that enabled the community to add literally hundreds of different kinds of tools to this platform. And that was the goal from the beginning, and that's what we've carried through. So that this i2b2, so what was it that we were trying to do at the beginning? We were trying to create software that could explicitly organize and transform person-oriented clinical data in a way that was optimized for clinical genomics research. And what that means is we were trying to allow integration of clinical data, trials data, genotypic data, all the data that you need to find associations and do work integrating EMR and utilizing EMR, clinical trial, and associating that with the genomic data. The second goal was creating this portable and extensible application framework so that additions could be made. And so software for i2b2 was built in this modular pattern so that it could absorb new units of analysis and infrastructure from our community. And as such, it's all available as open source at the i2b2 website. And this is kind of the canonical software module. We call the whole thing the hive. It's a beehive, you see, and this is a cell, a bee cell, and because it's very busy, I guess. And the idea here is that you can encapsulate all of your business logic, your data access and objects for your specific module, and allow communication between it and other aspects of i2b2 in a well-defined service-oriented architecture where RESTful messages, which have certain kinds of headers to organize the information and so forth, but allow a lot of flexibility in creating new ones, can allow these to interact. And so at the end of the day, you get something like you see here, where we have a whole hive of modules. The user who's a researcher or a population researcher or healthcare researcher of any kind, a genomicist, will use the client to ask certain research questions about their population, and then it'll go to this assembly of modules, of cells, in order to access the data, which you can see over here on the far left, which will contain EHR data, genomic data, clinical trials data. That data can then be processed through various modules, both locally built as well as remotely built, such as doing natural language processing, for example, which might need a de-identification module in the local environment in order to be able to report it out to a remote module that's the best of breed of a sort. And all this is available at this i2b2 website, which provides the support essentially for our community. And this is a somewhat outdated slide of many members of our community. I think what Zach showed you was a more up-to-date representation of who all has implemented i2b2 across both the US and internationally, as Paul will talk to you about very specifically. And the principle behind i2b2 is that it can allow two things. One is it can allow access into a repository where data is taken out of the EMR and put into an analytical data structure, which I'll describe in great detail in a little bit. And that creates an enterprise data repository, an EDR, which you can query and find patients, cohorts of all different types. And once you've isolated patient cohorts that you're interested in, you can do deep dives and have a totally new level of access where you can create these project-specific phenotypic data type sets and unite that with data from all kinds of other different systems and present it to researchers in kind of a more rich platform, which allows them to do much of the work that you've been seeing. The privacy levels that are available is a key aspect of i2b2. It begins with obfuscated data user access, where if you're looking at the enterprise data, you can only see not only just aggregate numbers from your custom queries, but also they're even obfuscated in a way that you can't ever identify a single patient, basically no matter how detailed the data is. And then that goes up to limited data sets where you'll often have your data marts, and of course things like fully identified data sets where, if you're recruiting them for clinical trials. And so here you can see we have a typical picture of the query tool. Over here on the right, you have the items that describe the patients, their diseases, what clinics they've been to, what different medications they've been on, what their demographics are, and all these are available to be put into what's trying to be a Venn diagram here, which is over on the right, which has a what are really trying to be circles of a Venn diagram. And so if you put something in one circle, it will give you, and you say run query, it will give you how many patients have that. So how many patients have been to the Brigham and Women's Hospital is what that would ask if I just put Brigham and Women's in one circle. If I then went and put in, sorry, I got to put my glasses on to see my my own screen here. So if then I went to look for malignant melanoma, if I had put malignant melanoma in with Brigham and Women's, I'd find all the patients who had either malignant melanoma or had gone to Brigham and Women's. That might not be very useful, but that is what you would get back as your result. While if I put malignant melanoma over here in another circle of the Venn diagram, I'll find all the patients who have gone to the Brigham and Women's Hospital and also have malignant melanoma. And that's what you'll get back. And then you can see I also put female here. So these are all the patients that were at the Brigham and Women's Hospital who had the diagnosis of malignant melanoma and were female. And you can do that with all kinds of crossovers and so forth. And then you can look, as Zach was telling you, in a much richer way when you get into your data mart, which gives you a higher amount of privacy, which protection in that to get to this stage, you often have to have a full IRB protocol in order to do just one study, as opposed to at an enterprise data level, because the data is obfuscated. You don't necessarily need an IRB approval for every study that every question that you enter there. You can just, it's considered non-human research. But then at this level, where you have detailed timelines of when patients, for example, were on bronchodilators and got prednisone for each patient, then it becomes much more important that you're going to have to get a full IRB protocol, but it shows you great amounts of detail on those patients. And you can build these kind of custom study displays, which you start with the raw data elements, which might be items in the enterprise data warehouse, which we call the research patient data registry at Partners, but that you make into calculated data elements. For example, from the raw data you have on Avandia prescriptions, you can tell when you think a completely, when they're on Avandia in a complete way, or you can tell when you theoretically have them in the hospital and they're kind of a computationally way enrolled in the study. And so see here we can do calculations where each of these pink bars say when they got a prescription, but then this green and red and yellow bar represents when we actually think they're on Avandia, and that's complemented by natural language processing results of when they're on Avandia from the notes that you see down here. So you can get a really good idea of when they're on the medication by doing these calculations. And then if you want to get deep into the patient and confirm, okay, well, that's what the calculations say, but let's actually look at it myself, you can go and pull up a smart screen. And what a smart screen is, it's kind of an EMR view. And see, here's an example. If we take cells that are the clinical research chart and the ontology and the project management cell here, and we add new modules for a new project, which was a smart project, which was going to allow us to look at these patients in an EMR-like view. And that's what it enables. It enables a new app to come up, and now we can look at patients in a new client, in a very detailed way. And that's basically the principle behind, how i2b2 works. And so it can, be by adding on new modules, it get you whole new functionality. In this case, adding these smart EMR-like views to i2b2. And that, you can carry these very far. So here, for example, is a smart editable EMR screen where you can rearrange different aspects of the patient on your screen, including their risk calculations and so forth. Ultimately, much of what i2b2 is used for at Harvard is understanding the phenotypes of its patients. And certainly the raw data in the EMR is not really very good in terms of like assuring you what the phenotype of the patient is. If you simply have it saying that they have depression or they have rheumatoid arthritis, that doesn't necessarily point to the fact that they really do. I mean, it's being used for lots of different purposes, this data, and it might be indicating different things. It's a good starting point. But then what we do is we validate by going and finding sets of patients. And so here you can see we actually look at the notes on the patients. We do use natural language processing, for example, to pull out whether they are smokers or not smokers, or at least what the notes say. And then we put into very complex algorithms like this lasso shrinkage algorithm that is a multidimensional analysis. And so here you can see we plot all of our patients with depression on a ROC curve. And this diagonal line, of course, is just random guessing. And this dashed dotted line right above it is what we would have guessed if we were just using the ICD-9 diagnosis of depression from these from our population of patients in the hospital. You see, it's almost like a random guess. But once we add in all of the different aspects that we can use to understand if they have depression, whether they're seen by a psychiatrist, whether they were on an antidepressant, whether they have things in their notes that say they are depressed, then you see we get a much better sensitivity and specificity in our OC curve. And that allows us to kind of weed our patients down in kind of a systematic fashion so that we can answer questions like, when Celexa was tagged as prolonging the QTC interval, what about Lexapro, which was not studied, but is simply a chemical enantiomer of it? And so we could actually, within a few weeks, put together all of the EKG results of QTC prolongation and compare it with the calculation of patients who are on Celexa. And you can see it actually shows that there's even a greater prolongation with Lexapro, which would have remained hidden if it wasn't for that. And you can do these in dose response curves, as you see here. And all this is fundamentally integrated by this data model that we have behind us, which is the key to integrating the clinical trial data, the genomic data, and the EMR data. And that's what we call a STAR schema. It's a very common business model for organizing data, which we've extended into the healthcare domain. And the central part of it is this fact table, which allows us to store many different kinds of data in a similar table and operate on them. That's kind of the key to the working of the system. And some of the dimensions that hang off it allow us to do further kinds of analyses. And it also allows us to do this flexibility of what we put into the data, into the database, and how we classify it. So for example, we can classify data either as ICD-9 codes, or here we have it as SNOMED codes. And we can put genomic data, such as these variants in the sequence ontology, so that we can express in the database whole genome sequences and exome sequences, or the results of the calculations from their VCF files. And you can do all kinds of queries representing, for example, what dose of medications patients are on, and what route they're taking, and how many patients are on a dose of 500 milligrams and took it, by mouth. You can constrain it so that observations in the same encounter, and you can do temporal queries because every observation is linked with the time that the observation was made, and that allows you to have these complex kind of temporal relationship displays. And then ultimately, we put the flexibility of i2b2 to the test by hooking it up in this shared research network that Zach was describing, and these are the hospitals that are involved. And we have some great deal of data that's really nothing more than a couple of extra cells that are put on the front of the i2b2 site instances that house the data at each hospital. And so by putting some new cells and allowing then a general client to compose a message, broadcast it out to each of these adapter cells, query their own local sites, and bring the answer back, we were able to, in fairly short order, be able to build this aggregate system that allows us to query many, many, many i2b2 sites at one time. And so, for example, we can, using this Shrine ontology in a query tool that looks just like i2b2, find all the sites that have patients on chlorpromazine, and then here who are on chlorpromazine and have bipolar disorders, and you see they're listed down here. So if you had a clinical trial and it needed 1,000 patients, you would have given up if you had just gone to Partners or just gone to Beth Israel. But here you'd see you're up to 600 patients already, and we've extended this into the Shrine National, which links together many different sites, which allows us to achieve much greater numbers and pull together clinical trials that can be multi-site and achieve the numbers that Zach talked about at the beginning of this. So that this would lead us to recruiting across several sites with Shrine, finding cohorts, finding doctors at institutions for sponsoring the clinical trial, creating a project at each site, and then being able to recruit the patients for clinical trials. And so here's some references that we have, and here's the websites that we have that house various aspects of i2b2 Shrine and smart technology.
Thank you, Sean. And then now I'll be presenting from how in the University Hospital in Paris we started from scratch the installation of the i2b2 clinical data warehouse 4 years ago with Professor Patrice de Goulet, the CIO of the hospital, and Eric Zapetal, the senior engineer. So what we did is, within our hospital in Paris, the HGP is one of the 38 hospitals with 600 beds, and this hospital was created in July 2000. Why am I showing you this slide? It's because the information system is as new as the building, and Professor Patrice de Goulet created a mirror database of the information system. So we were able to have a real-time copy of the production environment using our EHR system called DXCare, which is the equivalent of EPIC in France. And so based on this mirror database with all the different tables, PHI data, we were able to reuse this data as a starting point for the clinical data warehouse and for business object, EBMG rules, and to reuse this information in the context of research. So what we did is, instead of creating a new research clinical data warehouse, we used the i2b2 environment that was available. And what we did is to integrate all the different kinds of clinical data that we have available, the demographic, the vital signs, the diagnosis in ICD-10 codes, the procedures, the clinical data where we have questionnaires with answers to the medical questions, and the data started in 71, so we were able to reuse the data that was collected. Free text report, a total of 3.5 million free text report, pathological codes, lab values, antibiograms, drug prescription, and even the validation of drug prescription by the pharmacist. So we integrate everything into the i2b2 clinical data warehouse, and to enable physicians, medical doctors that were trained to be able to reuse this, to use the system. So the condition to use the system is any medical doctor or pharmacist that follow a training, a specific training on a 2-hour training on how to use the system, and of course that were working within our hospital. So for example, acute myocardial infarction and pulmonary embolism, 73 patients in 2.7 seconds out of a database with a total of 600 million facts. And this is what we call the level 1 of access control. So in total, we trained nearly 200 medical doctors and pharmacists. And something specific in France is that the IRB are regional. The IRB are not within the hospital. So it took us 2 years to convince the IRB at a national level to have a local representation within our hospital. So we have an antenna, a subcommittee of the regional IRB that meet every Wednesday, the first Wednesday of each month, to review all the i2b2 IRB protocols to have access to patient-level data. So the level 1, when you have the aggregated count, for example, the example I showed you, 73 patients, that is available for all the medical doctors with the specific training. And within 2 years, they did 2,200 requests by themselves to have access to this information. If they wanted to have access to patient-level data, what we define level 2 is anonymized patient-level data, so not being able to have the PHI information, and level 3, de-anonymized patient data, to have also access to the PHI information on those patients. So we created all this infrastructure from scratch because as I told you, we also had to have the IRB infrastructure to be able to handle those requests. And we have 35 projects that got the IRB approval. So it is very low compared to what they managed to do at partners. But we are in the situation where we started from where we had nothing at the beginning. And so one of those studies that were approved, I wanted to show you one of the examples, where in the context of a genome-wide association study, you have cases versus controls, and then you look at the systematic differences across the genotype. What we did is other way around, a Phenom-wide association study, where you have 2 groups of patients, on one side based on the genotypic information, and you compared all the diagnoses across all the phenom between the case and the control. And why am I showing you this study? Because it's an amazing use case that was able and easily doable with an i2b2 clinical data warehouse, because we used different data types we use for the same patient: ICD-10 diagnosis code, the drug prescription, the lab results, and the clinical notes. Everything with the different time points. If we didn't have a clinical data warehouse where everything was already integrated, this study wouldn't be possible. And this study, we only did it of 450 patients, where we look at the troponin activity, where when you have a troponin drug, it's metabolized into an activated metabolite and then eliminated. If you don't have the TPMT enzyme, it can increase the toxicity. So what is recommended by FDA and EMEA is to dose the TPMT enzyme or to do the genotyping of the TPMT gene. And within our hospital, both elements were done. So that's why we were interested in doing this study on this use case. And what was known is that there's 3 different groups: normal activity of the enzyme, intermediate or low activity, and then you would reduce the dose. What was unknown and we discovered is a 4th group. So in the context of precision medicine, of having subgroup of patients, we were able to discover a new subgroup of patients, and doing a FIWAS by making groups on a quantitative trait on the TPMT enzymatic activity between very high activity versus normal or low, creating 2 groups and looking the systematic differences across all the phenom, all the ICD-10 codes, and to validate within the lab value. So that's the main output of our study, where we look at, that's a Manhattan plot of a FIWAS, where you have here 256 base aggregated ICD-10 groups, and above the FDR, you can see that there's an anemia and diabetes, which is above the FDR. So there's a systematic differences between very high versus the other one, meaning that those patients are not treated enough. They have the disease that is still going on. So the drug should be increased in dose. And what is the quality? And that's a key point. What's the quality of having an ICD code saying anemia or diabetes when you have all the lab values in the same system for the same patient? So we were able to do an internal validation by looking at the hemoglobin level that was decreased and hyperglycemia for the same patients. And so that's one of the study we did. And I wanted to acknowledge all the team in Paris University Hospital. And that's what I wanted to present you. Thank you.
So we have a number of questions for you. One overarching one is if we could have references for the various papers you mentioned. And so what we'll do, Genetic Alliance will do, is after this presentation, we'll collect those from our 3 speakers, and we will send them out to all of the participants. So first question, does i2b2 allow extraction of highly granular clinical data for patient stratification? And a sort of second level to that question, can you do specific data, for example, the value of a glucose level at day X with a certain value? Can you get to that level?
The short answer is yes. The slightly longer answer is the typical way in which i2b2 is used is to identify, for the computer scientists, I'll say roughly the right data block of interest, and for those of you who are researchers, the right group of patients with the right characteristics and which data you want to extract based on the first level queries. Then extract that data, and there's a variety of utilities that we provide to do so, into another analytic tool such as R or SAS. And in that context, we want to be very clear that we do not intend for i2b2, nor have we designed it to be a substitute for all analytic packages. On the contrary, we see it as providing an enabler for people finding the right data about the right patients under the right consent procedures. And once we've done that, it really enables a much sharper set of questions, a much less noisy set of data, and a much more reliable analysis to be done by that focusing that i2b2 first provides. Having said that, there are an increasing number of i2b2 modules that have been written by third parties in our fairly large academic users group, which provide additional analyses at a deeper level. Some of these are plugins, some of these are other cells, some of these are smart apps, and that community is growing. And in fact, there's a direct a cell that provides direct access to the i2b2 data from R. So on the one hand, no, we want to have the data made available to other analytic environments, or yes, we provide community apps, plugins that actually allow you within the i2b2 ecosystem to begin or even complete your analyses. And speaking personally, for example, in my work at autism, I've done actually most of my work directly with the i2b2 platform and related apps. I'm looking at my two colleagues if they want to add anything in that respect. No, they do not.
Okay, thank you. Okay, let's see, let's go to, we'll sort of stay at this more middle level, and then we're going to actually drop down into some technical questions about the installation. But on the sort of more general view, can you speak about the IRB process and what were the main concerns raised by IRBs?
Sure.
Sean will answer.
So we often think of this as kind of a step one, step two process. So in step one, where you have the enterprise data repository that's being exposed through i2b2, the concern was that you don't want to expose your entire hospital population almost to anyone unless it's, you know, something that can't possibly get down to a single patient and identify a single patient. And so what we did for that is that we built the query tool in such a way that you can ask questions and get back cohorts of patients in terms of what numbers they are and some basic breakdowns of them, but you can't get down to a single patient. And just to make this totally airtight, we obfuscate the number a little bit. So we add a little bit of a random number to it so that you're never going to see the exact number. It really doesn't matter if you have, you know, if you see the aggregate number of 550,001 and 550,002, you know that, you know, there's enough patients to do your study or to make to get to the next level. But it makes a big difference in terms of people trying to break the system so they can find out, you know, if it's one patient that's very carefully defined, of course, in all the data. So because of that, the IRB will often allow queries to be done by, you know, anyone at the hospital, for example, who has a faculty appointment or who is employed or at the hospital, because it's non-human research. Now, there's still sensitive things in there. Don't get me wrong. I mean, you could still disrupt the hospital and by saying, you know, how many patients are there that have procedures where they had central line infections and didn't get treated with the right antibiotics, right? So you could still ask embarrassing questions, and so there's still a, you know, at that level. But from a human subjects protection level, it allows you to allow your data to be queried and not expose your patients to and their identities. Now, at the next level, so that's step one. At step two, you know, eventually people really do need to get down and dirty with the data. They're going to have to validate the data to make sure that, you know, at least a subset of patients that they're going to look into, you know, personally, they're going to take 100 patients out of maybe a 30,000 data patient set and say, okay, I've calculated that these have rheumatoid arthritis or these have depression, but I'm going to go and make sure, I'm going to go find me a set of patients who I really know if they do or don't have rheumatoid arthritis or depression, and I'm going to compare my algorithms to that. And for that, you're going to need, to get into their identities. Similarly, if you want to recruit them for a clinical trial, you're going to need to know their identities. And so the second step, after you've figured out you have enough patients from step 1, if you go to step 2, there you need full IRB approval, which usually is granted in a waiver because it's usually low risk. It's considered to be low risk research, and that it's only looking at medical records. You're not intervening with the patient. You're not giving them a new drug. You're not putting them on a new device that might be hazardous to their health. So, but then the people on that specific study will be able to see the full complement of the data to the extent that state laws and so forth allow. Lots of states have different laws in terms of, like, whether you can see HIV test results or genetic data that's from screening tests and so forth.
Great, thanks very much. Okay, so now a couple of more granular questions, and these are going to be about actually installing the software. So, and I'm going to group a bunch of them together. How long would it take to implement your own version of i2b2, and what type of support is offered? Typically, how long would it take to get up and running? Does it support the use of MySQL?
Right. So I'm going to start by saying that we make the software freely available, and it's free and open source. We provide documentation online, and there is a very active academic users group where people, various sites help each other out with ETL scripts and various debugging requests. However, we actually don't support the sites. And what's been remarkable is how successful so many sites have been with actually essentially no additional support from us. And this varies from site to site, from sites which have full expertise on board and are able to do it through their own local competencies, all the way to others who will contract with external organizations, sometimes for profit, sometimes non-profit, to actually do that implementation. I'll now turn to Sean to ask him to further elaborate if he has a comment, and then to Paul, because he's actually done this without our help.
Right. So, in terms of how long it takes and what skills it takes, there's two aspects. One is installing the software, and that takes a skilled person, usually maybe a week. We also have a shortcut. We have an i2b2 virtual machine that you can download that will get you up and running virtually within a day. But the second part is much more nuanced, which is i2b2 does not directly query data out of your electronic medical record. It has you take the medical, extract it out. So you have to do an extraction of data from the medical record and then put it into the data structures of i2b2, that star schema that I showed. And so that could go on virtually forever, right, depending on how much data you want to put in. So if you just want to get demographics out of your EMR and diagnoses out of your EMR, that might take maybe a month. But if you want to take all that plus medications plus labs, it could go on for years. And it's really just kind of limited by how many resources you have and how tenacious you are.
Exactly, and I would add from the Pompidou University Hospital, where you can have it's a really agile approach where you add additional layers. For example, at the beginning, you push the diagnosis code and as a first version, and then you add a second time, once you see it's working, you had the ability to query also on primary or secondary diagnosis. For example, for the lab value, we had more than 5 different versions where we have at the beginning only the value, and then the maximum, the minimum, the ability to query, the different measurements, or for the drugs where you had multiple additional information. So it's not, you don't put the drugs in one go. You add multiple times. It's a really agile approach to improvement.
Great. And then could you go just one step further and answer whether or not you can use MySQL? Is it presently using LAMP? Can modules be developed with things like C++? And is it using a data provider model so that any RDBMS can be used as the data warehouse?
Sure. So we don't support MySQL. We support Postgres, though. So if you want an open source database to attach it to, Postgres is supported. For the clinical research chart, the main data repository cell that is performing the queries and going against the star schema, it can be, you can use either Microsoft SQL Server, Oracle, or Postgres as your back-end database. Now you can build a new cell and it can use whatever you want. Because, and just to roll that into the C++ question, so most of i2b2 is built in Java and JavaScript, but the cells communicate back and forth in XML services. So you can virtually build a cell in anything, and as long as it is compliant with the XML of the services, it will interact perfectly well with the rest of the Hive in i2b2.
Great. So is the typical installation including only an instance with PHI that's obfuscated or aggregated at the user level when appropriate, or an installation with PHI and one without? And related to that question, how do you get the consent to see the identified patient info?
So typically, if you want to load i2b2 with PHI, and you want to do, that would mean that either one, it's only for a small set of users that are doing some kind of healthcare operations analysis, or you're doing a very specific project which you have IRB consent for. Because to load with PHI and have PHI readily available to a set of users, they're going to have had a waiver of consent at least for the patient. So by law in the United States, when you come to the hospital and you will be given a HIPAA notification, and if that HIPAA notification, that's the opportunity for a hospital to say that your data will be used for research. And actually, you have to have in the HIPAA notification the statement that your data will be used for research. Otherwise, you can't use the patient's data for research, and that's the law. Now, if you've given the notification to the patient that says they're going to use their data, and it's not a consent, it's a notification, it still doesn't mean that they've consented. And so then either you do need to consent the patient, or you need to get a waiver of consent from your IRB. And so typically when you go to the IRB to ask if you can do a rheumatoid arthritis project based upon EMR data only, what you're going to do is ask for a waiver of consent for the 30,000 patients that you're going to want to put into this i2b2 database. And in that IRB proposal, you're going to say things like, and only, these 5 people are going to have access to the data, and we're going to destroy all the data when we're finished with the study, et cetera, to limit, the possible exposure of patients.
I also want to point out that there's nothing hardwired about the consent model within i2b2. In fact, there are some implementations of i2b2 that model the different consents that are in the system, and B, I should note that in the large range of institutions that have adopted i2b2, many have adopted the same consent model that Sean just referred to, but a few have adopted a model that allows for some patients to have a broader consent that, among other things, allows for recontact.
Great. Now, I have 5 questions left and 2 minutes, so we're going to try to do it. Building on response regarding the time to implement, do i2b2 tools enable mapping of EHR-coded data, for example, Snowman and Loink, into the i2b2 schema?
Yes.
Good answer. What capabilities would Transmart give beyond i2b2?
With Transmart, you can have an analytic tools that is on top of it, because Transmart is a huge plugin based on the i2b2 model, but there will be a specific webinar presenting this. So that's one of the advantages.
Wonderful. Yeah. Good advertisement for upcoming. What is the impact on the natural language processing analysis of such widespread practice, such as copying and pasting or the use of macros?
It degrades the quality of the data. But what we have seen is that when physician groups, start becoming aware of i2b2, there is this amazing effect that I've never seen before, that they improve the quality of their documentation, because now it's no longer for a faceless bureaucrat involved in reimbursement, but they're actually using it for their research. So we've actually seen many times now improvement in the quality of documentation because they're now able to surface their data for their research.
Great, excellent. And then last question, i2b2 is obviously a trailblazer, but what ways would you like to see it improve?
Well, the way I would like to see it improve is to, first of all, tactically, I think a lot more interesting things can happen if the connection between the i2b2 and the EHRs is no longer a batch recurrent process, but a real-time process, so it reflects in real time what's happening in the electronic health record. I also think that i2b2 should and will, in fact, become a member of a larger community, I think, of analytic applications that look at a variety of populations. And whereas i2b2 has focused specifically on, in this case, on genomics and clinical, there are a large other set of domains, perhaps environmental, quantified life, that i2b2 needs to plug into, sometimes directly by incorporating it, but frankly, other times by just being a member of a community of analytic applications. And the third thing that I would like to see in i2b2 is something that we also are planning, is how to use it much more directly to recontact patients for a variety of applications, including the one highlighted by Sean, namely patient recruitment. I'm now going to end, unless you have another question, by saying that we thank everybody for their attention, and we want to put in a plug for 3 more webinars that you, Sharon, are hosting. One about our distributed query system, Shrine. One about our system, Smart, that allows both i2b2 but also electronic health records to have these healthcare apps running on top of it. And then, last but not least, Paul will be providing a seminar webinar on the Transmart platform. And with that, I'll thank you. And if there's no other questions, we'll just say goodbye. But if there's a question, we're glad to answer.
Okay, super. You actually got through all the questions. I want to thank you, Zach, Sean, and Paul for an excellent webinar. And as Zach pointed out, we have a whole host of them coming up from this team. They are quite prolific and give us a lot of tools, so thank you again. I'll also call the audience's attention to the screen right now. Our next webinar is Tuesday, June 3rd at noon, and it will be on the PCORI methodology report, which essentially came about through a methodology committee putting together a document that is helpful to especially patient-centered outcomes research. So join us then, and as Zach said, join us continually throughout the rest of at least the summer, and if these guys keep coming up with more ideas, or any of you have ideas, we'll be into the fall with this series as well. We're really delighted by the attendance and by the quality of the presentations. So then, again, thank you to our speakers, and have a good day, everyone.
Bye-bye.
Thank you.
Bye-bye.